my job today is to talk a little bit about research, because I am a researcher and that's what I do, and to put in the context what we know and what we do not know about low-carb diets or diet in general for type 1 diabetes, but most importantly for kids with type 1 diabetes, because I'm also a pediatric endocrinologist. So my patients are children, and children are not small adults. They have unique physiology and psychology and health and body. So I think it's important to take pause and think about what's right for kids, what's right for adults. So here goes. This is my team in Boston. So I work with this lovely group. This is my mentor, David Ludwig. He's a well-known nutrition and obesity researcher. Most of you have heard of him. He's come to meetings before. And I actually come from an obesity background, researching low-carb and low glycemic index diets with him, until I, more by chance, really came upon the type 1 GRIT group and heard about your guys' approach to type 1 diabetes. And I was like, man, that's so interesting. And so this got me started, and I haven't turned back since. Then research assistant, Dr. Azova, is an endocrinologist in my group who does research with me and who has an interest that's very complementary to me. I'm interested in physiology and health and metabolism. She's really interested in how patients perceive diet and nutrition. So she's doing a lot of work in our clinics right now as to why is it so hard to change people's attitudes and minds about how diet, about eating? How do people feel about nutrition? Do people want to have advice about their nutrition? Do people want to change their habits? And why? So that's what she does. And that's, I guess, the entry to our hospital. It's too big to fit in one picture, so just the doors can go in. So I wanted to just preface this, and I said this at the last meeting, but new audience, so I preface this with a comment on nutrition research. Because nutrition research is probably just about one of the hardest fields in research that there is, if not the hardest. Why is that, right? So nutrition is not a medication. If I want to do a medication research, I could just give someone the medication or a placebo or not the medication. That's the easy thing to do. Nutrition, not so easy, right? I've got to get people to eat different. It's easy to do that in animals. So there's a lot of nutrition research in animals. And I think a lot of the conclusions we take for the recommendations or the approaches we take to humans are kind of based in animal research. High fat, low fat for rodents, for example. But if you look at the high and low fat or different diets for rodents, they're not composed in the way that a human diet would be, and they're also not necessarily, rodents aren't necessarily the same as a human, right? But so we can do, mechanistic physiologic research in animals, and that's important. I don't want to minimize it, but it's not that can be the end of it, right? Oops, sorry, I keep confusing those buttons. We can do research in humans, of course, right? And so there is two major lines: observational, which is we observe what a certain group of humans do, and we describe, and we look at their outcomes and their health, and we describe that. And then there is interventional. We get people who are not doing a certain habit and get them to do it, right? And so then we can directly measure their outcomes. And both are important. So the observational, we could, sometimes you pull a group of people, like when I pulled the type 1 GRIT group, that's a group of people who are eating a low-carb diet, and we were able to describe their health outcomes and diabetes control, which were amazing. So that's really inspirational, but it doesn't really answer the question, would that work for another group of people, right? Like you might believe it would, but it doesn't prove that point. And so it always raises the question, is there certain things that those people do in addition to the diet? So maybe they do diet and exercise, and maybe it's the exercise and not the diet, or maybe they have maybe they're just more diligent, or maybe their health was different in the first place, and so maybe that's why they're doing so great, right? So those are the questions that come up if you present an observational study. Also, if I poll, the people who responded to my survey. I know they did great, but I also won't know how many people tried this approach and didn't do so well and stopped because of it, and then would have never come to the stage where they took the survey. And so that's why we're beyond excited for the survey findings, and they're really revolutionary. It doesn't really yet quite suffice to get our point across. And then the interventional ones is where I kind of bring people in from the street or, from a group of, I recruit volunteers and I give them a certain diet or expose them to intervention. That would answer that question a bit more definitively, right? Because those are ideally, if the research is well done, those are kind of random people just like everyone else, and then I do something to them and just change the diet, for example, keep everything else the same. Have a comparison group where I don't change the diet and keep everything else the same. Optimize, give them the same insulin, give them the same diabetes care, everything the same, just the diet. And if I find something there, that gives me a more definitive answer to my question. However, those things are very hard to do. Especially because some of the outcomes we're interested in are long-term outcomes, right? Like if I want to know about my cardiovascular health, about my risk of dying from a heart attack, those are kind of lifelong, very long-term outcomes. And it's quite frankly impossible to recruit someone off the street and ask them to eat the same diet that I decided for them for the rest of their life with other group that eat a different diet no one's going to participate in that. And so that's why those interventional studies, while they're very good and high quality, they're usually pretty short and don't allow us to make any definitive conclusions about the long-term health. They do in combination though with observational studies and animal studies and interventional studies. In the whole repertoire of types of research we have, we can create a picture that eventually is going to be compelling and give us answers to our questions. And I'll talk about some of those questions, some of the known and less known ones later in the talk. To set the stage, I know this is a diabetes audience, so most people will know what I show you here, but I'll just briefly, for the sake of people who are not. Blood glucose is what we're measuring in diabetes, and we've heard people argue, would it be better to measure insulin if we could? Does that matter more? And it probably, does, but what we can measure right now is blood glucose, and so that is governed by two things, like how much glucose goes in. Like we heard from Dr. Westman, an apple has 20 grams glucose, there's 5 grams in the bloodstream, so a lot goes in. And how do we get it out, and where does it go? So getting out is all the research that I know in the medical community is focused on getting it out, right? Like insulin technology, devices, better insulin, and so forth. But a system doesn't work like that, right? We've always have to consider both legs of it. So getting in and getting out is important together. And I think this is largely governed or exclusively governed by diet, really. The other thing that's interesting is where do things go when they go out. So insulin does not just clear glucose, it puts it into the cells where it may or may not be useful. And only if our blood sugar is very high, above 200 milligrams per deciliter, will some of it get spilled in the urine and take water with it, make us pee a lot, be very thirsty, and so forth. Not the best thing either. So I think we just have to be more mindful of what goes in and what goes out. Insulin is given as a basal insulin for the daily needs, plus multiple daily injections or boluses to cover the meals, for which the boluses are usually largely used for carbohydrate. And I spoke yesterday about how there's a mismatch about how fast insulin acts and how fast carbs act, and not every carb's the same, not every protein's the same, and it's not surprising that we see CGM curves like that in clinic almost every day, right? So this is a kid they do not have very good diabetes control, but at the same time, it's not completely outrageous. Like we do see that every day in the endocrinology office, where your blood sugar, this is the supposed target range, which is 70 to 180 in the green. And I've heard several people mention yesterday and today that that doesn't seem to be a satisfactory range in a lot of people's minds, even though it is the recommended range right now. And maybe it's recommended because that's what people think can be realistically achieved, based on population data. But we see commonly excursions outside that range. And then the bottom one is what I would consider a very well-controlled patient if they're eating a standard carb diet, right? So really good control. And you see what the problem is, right? It's not the overnight period, the fasting. Like if a person doesn't eat, it seems to be working out fine, but the second they start eating during the day, they have these swings and ups and downs. And commonly what happened is if once you go high, people feel compelled to take extra insulin to correct it, overshoot a little bit, go low, then eat a lot of carbohydrate to bring it back up. Like you go in that roller coaster. State of diabetes control is frightening. So the American Diabetes Association recently changed their recommendation to ask for a hemoglobin A1C of less than 7% for kids, which is the same recommendation as it is for adults. They used to ask for 7.5 in kids because everyone knows kids are harder, and it used to be that tighter control was associated with more hypoglycemia before we had very precise ways of measuring blood sugar and handling this. So it wasn't never recommended. So the higher recommendations were to account for the risk of low blood sugars. And so this is 7 now for both adults and children, and this is what can be accomplished across the age range, right? So birth to age 70 years, average hemoglobin A1C in the US. And you can see that adults do better than kids, but teenagers really do the worst. So A1C increases, puberty, and then kind of gets a little bit better, but the majority of people do not achieve those targets. This is not recent, but this is data from around 2018-19 here, this curve. And this is data from a decade earlier. So not only are kids not achieving the recommended A1Cs, it's actually getting worse. And that in spite of all the major improvements we've made in terms of technology. So here is a newer study. This is with a closed loop system or a bionic pancreas. That's the state of the art that there is, where an insulin pump gives insulin continuously, reads out the numbers from a continuous glucose monitor and adjusts the insulin administration to give more insulin if the blood sugar is high, and decrease or stop the insulin if the blood sugar is low, and that should keep you in range, which it does overnight, but not during the day. And so this is the effect of that technology on the time spent in the glycemic target range. So the ADA says that should be at least 70% of time spent in the glycemic target range. And here I put 70% here by percent, 70% here, and then this is the percentage of people who do not achieve that. This is kind of a brain twister. Who do achieve it, yeah. So, everyone achieves at least 20% here based on that study. 100% of people achieve 20%. And then fewer and fewer people with a standard of care, which does not involve this closed loop system, achieve higher percentages. With the closed loop system, it's really helped more people achieve the recommended targets. But once you get to 70%, the new technology isn't all that different from the standard of care. So we don't have a lot of it's great, it helps a lot, but it's not the end of what we're looking for. In addition, there are studies that kids with type 1 diabetes do have a higher risk of obesity and metabolic syndrome compared to kids without diabetes, and that's due to the higher insulin exposure of the peripheral tissues. And it actually gets worse with intensive therapy. So the more insulin you give, the more you optimize blood sugars without watching your diet, the higher your risk for obesity. So this is kind of an older study, but one of the important ones to look at diabetes complications in 1,400 patients with type 1. And so the patients that received the intensive insulin therapy compared to the conventional insulin therapy gained 4 kilograms more over the course of 5 years, and that was sustained 10 years later. We know low-carb diet can be, a low-carb diet can be a helpful approach, and I think that it's gotten close to mainstream recommendation for type 2 diabetes and for obesity because the weight loss findings are compelling and had worked better than most other diets for long-term weight loss. Any diet, by the way, I think works for short-time weight loss, but what if you're going to want to sustain that weight loss for a prolonged period of time? And I think that carbohydrate reduction has really championed that field. And so then makes you wonder, how does it work for diabetes? So it could look to type 2 diabetes, it's working well. There is, as Jessica pointed out earlier, the breadth of research showing that a low-carb diet can work well for type 2 diabetes. Now look to the kids field, it's much more limited, right? Because kids don't have type 2 diabetes that often, and it's usually adolescents, and then for some reason, no one does studies or research in kids. So I found this 20-person study in adolescents with type 2 diabetes who were able to reduce their A1C on a relatively low-carb diet. So good, on a low-carb diet. It gets a lot more meager when we look at type 1, and I'll explain to you why. I'm not quite yet satisfied with this evidence we've accumulated. But just kind of to take a step back here we've heard from Dr. Westman earlier about the history of carbohydrate recommendations and research. But I just wanted to point out, in addition, from when insulin was invented and everyone was in very low-carb diet to today, we're focusing all our efforts on insulin and technology and not thinking much about diet. There's been a kind of a long phase of gradually loosening carbohydrate recommendations over time. And I used to say it's because there wasn't any research. They just did that without looking at the pros and cons, but then I sat back and took a much closer look at the literature, and I spent my whole COVID year reading hundreds and thousands of really old articles about diet recommendations for diabetes, period. And came to think it's not true. There was actually, valiant research effort to look at how much carbohydrate, or is it safe to eat more carbohydrate when you have diabetes and take insulin. But two problems: A, they couldn't distinguish between type 1 and type 2 diabetes, and B, they didn't have the means to measure any of the outcomes we measure today. So they could measure blood glucose only when they came to or urine glucose only when they came to a doctor's visit. So the outcomes they were looking at were DKA, and so it's the question is, do you get more DKA if you eat carbs? No, probably not, as long as you take insulin, right? Because if a person takes insulin, they're not gonna go into DKA. And so I think that the conclusions they made on being able to increase the carbohydrate amount in the diet were probably valid based on the methods they had available. But we've come a long way in terms of being able to measure blood glucose continuously, ketones, any blood insulin level. So we can do better today, I think. And here's my inspiration. We know the hope, the pros and cons. I'll skip over that. And then this is what we I don't have to go over all of these, but my 2020 project with a review. So this is the studies we pulled out from the thousands of articles we reviewed at that time. And we at the time had asked, we want to have only studies where people report to have consumed a low carb or a certain amount of carbohydrate for at least 3 months. And we didn't want to say, I did that today. So, And we obviously we wanted that hemoglobin A1C should be reported and some other stuff. So a lot of the research we couldn't really use because they didn't either report that a person was on a diet for a long period of time, or they didn't report diet intake at all, or they said it was low carb and they didn't say how much carb. And so it's really interesting, it's really difficult to make a good use of that kind of pile of literature if you don't know, how they define low carbohydrate. And so what we were able to only pull stuff where we knew exactly, or where it was reported at least exactly how much carbohydrate people ate and for how long, and then sorted it sort of by moderate, low, and very low carb. And very low carb, we said at least less than 50 or less than 10% of the diet, and then moderate 50 to 130 and 10 to 25, low, and then moderate 26 to 45. So here is what we came up with, and then it kind of goes, when you look at the lipids and the A1Cs, you can see the A1Cs are kind of in that 8 to 9 range here, just like it's published, closer to like 7 here in the low carb, and then really low, like 5s and 6s, and 5s mostly in the very low carb. And what's interesting here, though, if you look at the number of people who participated, I can't even read the slide myself, but I'm here to talk and not to show you slides. The number of children in those studies, so this study, 11 people, 1 child, 1,102 people, 0 children, all adults. Here, 1 child in this study, 131 kids in this study. What could that be? Ask Lester. And 1 child here, 1 child here, 1 child there, 1 child. So like a total of like 6 or so kids plus the 131 that incidentally came from the survey we did with a type 1 grid group. There was some newer research, and Jessica spoke about hers, and that's not included in this review, but Andrew Kudnick is doing a systematic review right now, and that should be here shortly. I can't talk about it because he's going to be the first one to present it. So very little, right? And so then here it's, case reports, observational, retrospective chart review. Here, RCT actually. RCT, but 1 week long, and only 10 people, none of them kids, right? So this is the online survey we published that included kids. And so what I could kind of say, I've presented that data before, so I don't want to be super boring and do it again. But people achieved amazing hemoglobin A1C. They had a little bit of a bump in LDL and total cholesterol as we expected, but they had very low triglycerides and they had a pretty high HDL, and that's what we found. So I just wanted to go, instead of doing single studies, address some of the concerns that people have had about low-carb diets for kids, because clearly there is no definitive study for children with type 1 diabetes. To be fair, there isn't really a definitive study for kids with type 1 diabetes and nutrition at all, right? And so to go back and come full circle, think about the guidelines, like they recommend. So there's 3 governing bodies for nutrition in kids with diabetes. 3 major ones that people look to in America or in the U.S. So the ADA, American Diabetes Association, comments on nutrition for kids with type 1 diabetes. The ISPAD, International Society of Pediatrics and Adolescent Diabetes, comments on nutrition for kids, obviously. And then the American Academy of Pediatrics. Like, those are the major bodies that kind of make nutrition and dietary guidelines and recommendations that people look at. And understanding how those guidelines are made and how the process is, I can understand that they are not quite ready yet to endorse a low-carb approach, right? But to be fair, is like what's recommended right now isn't also supported by research. It seems like you need a lot of research to change a guideline. You don't need a lot of research to keep one in place, which is unfortunate for us. But I want to take it upon me to provide a bit more research to come to a more informed process. So the concerns that most common concerns cholesterol, right? Everyone's like, what about the LDL? What about the total cholesterol? Is that gonna be dangerous? So again, not a lot of data available in kids, what those numbers are, but from the survey that we did, it seems like cholesterol is a bit higher than what you would expect for someone who does not eat a low-carb diet. But when you look at the DCCT, and that's that large trial that I mentioned earlier with 1,400 people with type 1 diabetes, and they looked at the most important cardiovascular risk factors in people with type 1 diabetes, they found that by far the biggest impact was made by hemoglobin A1C, followed by triglycerides, and the LDL was a not even close third. So while there is no studies to directly understand the long-term implications of that lipid panel, you might wonder if I can positively impact two important risk factors and make a less important one worse, maybe it's worth considering that would be worth it. Then what I hear often is the concern for ketosis or ketoacidosis. When you say ketones in the setting of type 1 diabetes, everyone's immediately through the roof because the big wolf in the room is ketoacidosis, which is a life-threatening condition. If you do not take insulin, you have uncontrolled ketone productions, and because insulin is your signal, right? Like it's your fasting signal. If you fast, eventually you trigger lipolysis and fat metabolism, and ketones is a byproduct of fat metabolism. And in a healthy person, once your ketone level reaches a certain cut, you automatically make insulin to keep that in check. Person with type 1 doesn't have that luxury. And if you have absolute insulin deficiency, your ketone production could go through the roof. You could have very, very high ketone level, something that would never be achieved by a fast. And that would kind of increase or lower the pH in your blood, cause acidosis. You also lose a lot of fluid from hyperglycemia that comes together with ketoacidosis. So you'd be dehydrated and have a very high ketone level. And but nevertheless, that thought is so prevalent in people's minds that physicians as well as patients always think about ketoacidosis when you even say k, right? So the difference, we made this table, if your blood sugar is normal, you could still have euglycemic ketoacidosis, which is a whole different story. But if your ketone level is between 0.5 and 3, it's or 5. So we did a study in our ED where kids came in with type 1 diabetes with a concern for ketoacidosis. And the way to confirm ketoacidosis is by measuring the acidosis, right? If you don't have acidosis, you don't have ketoacidosis. So they looked at a large number of medical records for kids coming in for a concern for ketoacidosis and measured their pH and found that a cutoff of about 5.2 predicted whether they had a risk for being in ketoacidosis or not. So those are kids in the ED. That may not apply to kids who do not come to the ED, but it's pretty safe to say that I think the spectrum of ketones you have on a ketogenic or low-carb diet is very different from the ketone level you have if you have ketoacidosis. And even without a RCT on the topic. Hypoglycemia is another concern. We've heard that often. If you go on a low-carb diet and you don't reduce your insulin doses, you will have hypoglycemia. It's very obvious. But what we need to do is take a closer look at, what happened. Could you potentially reduce your insulin dose to the point where you don't have that? And I think you could, but that remains to be proven. And glucagon, so some people will say glucagon may not work. If you have hypoglycemia, and glucagon is a very important rescue medication because it releases glycogen from the liver to increase your blood glucose level immediately to treat a hypoglycemic emergency. Liver stores glycogen by, glucose into glycogen. So if you don't eat carbs, do you have enough glucose in your blood to make glycogen? I think yes, because your blood glucose levels are pretty normal. Also, we can make glucose from protein, but it needs to be proven. This is a 1-week study. Oh, sorry. Always click finger. Oh. 1-week study where people ate a very high carb compared to a low carb diet, and they were given insulin to drop the blood sugar low, and then were given glucagon to see the response. And they found that the people on the high carb diet responded a little bit better to glucagon than the people on the low carb diet, and so they wrote that up as being concerning. But honestly, this level of a response is more than sufficient. The other concern is it's just kind of a 1-week study, so people wonder, what about the long term? So that's the other kind of question to be addressed definitively. And then, I showed you how there is like about 6 kids in the case reports and studies minus the type 1 grit survey. So there's a small number of kids that we have research for. And we have about a similar number of kids that's published who did a low-carb diet and had poor outcomes from other authors. So if you put that body of evidence against each other, like we don't have very much outside the type 1 grit survey in kids. And so this is a paper that you may have seen from Australia where they polled physicians and about patients eating a low-carb diet, age 3 to 15, and having any concerns. And so the concerns was, poor weight gain, weight loss, poor growth, high cholesterol. But when you review that article, it sounds like all of them were eating a hypocaloric diet. Like none of them were getting sufficient calories in, and they had insufficient intake of a variety of other nutrients. And so that was linked back to the low-carb diet, and I think that's not quite fair. Like I do think a low-carb diet could be nutrient sufficient, but maybe there is a risk that it may not be. And so that's why I always advocate for dietitian support to make sure. Self-reported here from the type 1 grit survey on growth. People have wondered about growth. So I'm comparing here a limited data set of growth data from the type 1 grit study. And so being very careful, I only took out the growth data from kids who had provider-reported growth data, so from their physician and not from self-reports. And who had at least 2 growth measurements, one at the time of diagnosis and one at the time of, of the survey. And so I can kind of publish how long they've been on the diet and how long those are apart, and I can plot them on a growth trajectory, because it doesn't help me as an endocrinologist or anyone with common sense. It doesn't help you to look at how tall someone is, because people come in all sizes, right? And so you need to look at how they're growing and how they're changing in relation to their own trajectory. So we pulled out that data. It's only 34 kids, so it's not very much, but that's all I have right now. And looked at their growth from diagnosis. And so that can be measured in standard deviation. So standard deviation is how far someone is away from average. And so that should stay the same. Usually it stays the same. So what I saw for these kids is that they actually did have a little bit of a lower height standard deviation score at diagnosis 2.3, and no, that's here. At diagnosis 0.41, and then 0.2 at the time of the survey. So their height actually, they didn't grow as quickly as I would expect a healthy kid to grow. But when I compared it to this study in 1,800 kids with type 1 diabetes, in their growth chart, they grew about at the same rate as other kids with type 1 diabetes. And I think that opens a big can of worms, right? You could say, okay, they grew just like all the other kids with diabetes. But, you wonder, should they have maybe grown better if they had better control? I don't know. But I think it's hard to then discredit a low-carb approach if they grew just as well, at least just as well as everyone else. Psychosocial, kids with type 1 diabetes do have higher incidence for eating disorders or disordered eating, about 2-folds than healthy kids. And so a lot of people worry and there is evidence that if you put a person on a restrictive diet, that increases their risk for eating disorder, right? So now I have a population that's also already at risk, and I restrict their diet. Do I now increase my risk, right? But I've heard people argue as well that does it decrease their risk because they feel better, they worry less about diet, they stress less about how food impacts their blood sugar levels. And what I'm hearing from you is that you worry less about diabetes and eating and impacts of food than before. And so could that maybe be protective from developing an eating disorder? I think that's the big conundrum. No one knows. So an additional venue for research here. And then we spoke about all right, summary is we don't know very much about optimal nutrition for kids with type 1 diabetes. What we see makes sense, but and it convinced me to change my career trajectory, but it's not going to be enough to change the major medical guidelines. So 2 years ago, David Ludwig and Andrew Kutnick and myself put out this long list of research asks that ranges, and I only included that for your slide deck, not to be looked at today, but asks for the types of studies and the topics of studies that we would like to address or like to see addressed. I can't do this all by myself, so I need help. But mechanistic, where we look at how certain compositions of the diet could affect blood sugars, maybe in the short term, maybe in the long term, how diet technology can improve, how diet and technology together can maybe get better improvements. Does protein content matter? Then, behavioral aspects. How do you get people to do this? Do people like this? Can people stick with this? How can you promote this in the long term? Effectiveness, does it actually, how does it actually impact your blood sugar control over time? If it's dictated by if it's recommended by a provider versus patients self-selecting and succeeding with it. How could this work for everyone? And how safe is it for kids? So long list, pull it up, see if you can find any research that will help. What I'm started at doing is I'm doing this RCT currently. It's 32 adults granted because I couldn't do it in kids as a first step. The IRB wasn't too excited about trying something like that in kids first, so I'm doing adults, young adults at that, and we are actually doing food deliveries to get all their food delivered because it's very difficult to change a person's behavior and know exactly what they did. If we give them all their food, we know what they ate, and we ask them every day, did you eat all this? Did you eat anything in addition? How'd it go? And for 3 months, and we have a bunch of experiments in there. We have a glucagon challenge to see if glucagon is really going to work even after 3 months. We have MRI tests to see how brain function, and especially brain function during hypoglycemia, might be affected by a low-carb diet. Some people think that if you eat low-carb enough and you have high ketone levels, that could fuel your brain, and you might be protected from some of the impacts of hypoglycemia. I've heard people say, if I have a low, I'm not as symptomatic, or I'm not symptomatic. So we want to measure exactly what happens to the brain. So we actually put them in the MRI, and we drop their blood sugar from all the way to 50, and keep them there and let them do a battery of cognitive tasks and measure brain activity to see what the brain thinks of that. There is a study, an old study, where people took healthy adults, 9 of them, and dropped their blood sugar all the way to 9 milligrams per deciliter in one case, and apparently they did fine. Not going to repeat that, so 50, we'll do 50. So this is just I thought I know you knew that, but I thought you'd like to see this. Like, this is the blood sugar control of a person before they started the study and after they started the study. So this is their CGM time and range before and after. So got quite substantially better. And then I'm doing a second large one that I'm just planning and starting up next this month or next, actually, in kids. And so we got approval to do a ketogenic diet in children with new onset diabetes between the age of 5 and 12 years, this one. And so again, those kids are going to receive their meals, and their families are over time going to learn how to make some of those meals of either like a very low carb diet, and that's like about 5% carbs, 75% fat, 20% protein is what we're looking at, compared to a standard diet for 9 months. And so what we're going to look at is glycemic control, obviously, and we're going to look at a lot of those safety questions we had, because I think that's crucially important to move the field forward, is to demonstrate safety, at least in a short-term studies. We're going to look at hypoglycemia, lipids, ketoacidosis. So we're going to do all those steps, but also what I'm really excited about is I'm going to look at beta cell function, because I've heard some case reports where people use the very low-carb diet to prolong their honeymoon period. So we want to kind of actually look into if that's measurable, because sometimes, if you look at the case reports, sometimes people do have a very long honeymoon period. But if I put people on one of two diets and the one group has a longer honeymoon period than the other, I think that would be really, really interesting to know. Why do I think that could be possible? I think it could be possible because I heard from all of you that you've known people who experienced that. But also there is some studies that show that a ketogenic diet impacts the gut microbiome in a way that could be conducive to slowing down the immune process. And that's all that I can do. But if more people could do research, I think we can build a patchwork of studies and work, and maybe over time have answers to some of those questions that seem obvious to logically thinking people, but just haven't been demonstrated enough to change any major practices. And before I stop, I wanted to thank people. So Andrew Koechnick is a big one to thank, because he's been involved with the JCI review. He's helping me plan the current study. He's a consultant. He's helping me think about how to put people in ketosis if they have type 1 diabetes. And then I have, the Dykmans have worked with me. Carrie Diolas, Sarah Hallberg has been a collaborator on this. And so thank you all for helping.